is Ardith Campbell. She is a content product manager here at Vitalware, and she'll be walking through the content today. Ardith, I'll hand it over to you.
You're right. That was fast. Okay. And so our basic disclaimer, we're doing as much as we can to make sure that this is correct as of today. However, we're not promising anything for tomorrow. Just nothing that pertains necessarily to the E&M codes, but there have been some changes to the vaccine administration since the Pfizer vaccine has been given emergency use authorization. The CPT codes, the 91300 and the 0001A and 0002A, they were initially published with beginning dates of November 11th, and that date has been changed to December 12th. And the AMA has also updated some of the parenthetical notes regarding vaccine administrations. So like the 904, 71, and 72 should not be reported in addition to the 0001A and 2A codes. That is not in the CPT errata documents, but it is in the where they have the vaccines listed on their websites. So today we're going to do an overview of the 2021 CPT evaluation and management code changes. We'll talk about time calculations and what can be included in those time calculations, the updates to the medical decision making, and then we'll also discuss the prolonged services and how to report those. What I want to caution you about, though, is that this applies only to the 99202 and the 99215 office visits. So it's the outpatient or the office visits and other outpatient services, and it also applies to the prolonged services codes. There is going to be a rollout into the other sections because they are going to discuss how the codes are used by the different specialty societies. And so I'm not sure if they'll all be ready by those specialties by the end of the year or what have you. They're supposed to have a meeting on February 4th to start discussing some of that. So there's no estimation of a time completion. Now there's really no change for facilities reporting the G0463 code instead of the regular E&M visits because the facilities should continue to use your own E&M coding guidelines. There's no change to that. So the only ruffle in there is that CPT code, the 99201, is going away. So if you had that set up, you'll just have to readjust your calculations to get the new codes. And let's see. Now we'll do just an overview of the changes. So there's a revision to the descriptions and the medical decision making. There are new guidelines for using time for the E&M codes, and the specific time range is provided in the E&M code description itself. So there's no need to hit the mid-range to bump up. For those codes that would say, did this, 15 minutes, where, you'd have to hit 8 minutes to be able to report that code. That's not really going to apply anymore. Now, the one exception that we might see in here regarding the new codes is the emergency department levels. The AMA said they may not change those. So we'll have to see how things shake out after they talk to the different specialty societies. And the definition of time is only going to apply, or when you use time only for your code selection, it's only going to be based when you're using time and not medical decision making. And the definition of time is the minimum time and not the typical time, and represents the total physician or other qualified healthcare professional, which is the other providers that can report evaluation and management services. So that would be your nurse practitioners, your physician's assistants. And the use and the date of service time allows the work involved in non-face-to-face services of the physician, and time spent on the days that are not the date of service does not count. And then through all of this, there are some new prolonged services codes. You know, you're not going to be wanting to get rid of your 95 and 97 documentation guidelines yet, because you still have the other rest of the E&M ranges that are going to be able to use those. But they did provide a groundwork for documentation, but it really ended up leading to note bloat. And so instead of making sure, you know, the physician or the provider making sure they are checking enough boxes to warrant a level of code selection, the new system will allow for the providers to use either the medical decision making or total time to determine the code selection. And so in a history, or excuse me, an exam is not part of the code selection any longer. And you know, for some patients, they don't really need a hands-on exam. And the old system, the 95 and 97 guidelines, really didn't allow for all of the coordination of care that can go on behind the scenes. So time may be the only component used for code selection, except for the 99211. The coordination or the counseling and coordination of care does not have to dominate the visit. It can be just the exam and also discussion. Time is stated within the specific service description, so you don't need to use that mid-range bump. And so now what it does though, is it causes the different categories to use time differently. So make sure you're reviewing the guidelines for each one. All right. So, so this information here from this slide has been added to the evaluation and management guidelines. And notice that the instructions state that this includes both face-to-face and non-face-to-face time. And I did add the bold font in the red just to kind of make it pop. So for coding purposes, time for these services is the total time on the date of the encounter. So anything done the day before or 2 days after is not able to be counted for time. But time is not always the only reason why you would code the visit that way. And we're going to discuss what things can be, what's included in those time calculations when we get down into the presentation a little bit longer. All right, so the 99201 has been deleted at the end of the year with the suggested replacement of the 99201. So really the only difference between the two codes was the level of medical decision making. And the AMA feels that if the physician is seeing a new patient, there is some type of medical decision making going on that is usually higher than the self-limited or minor. And the self-limited or minor, that's a condition that usually you could call your mom and she could tell you how to take care of it. And then also the AMA felt that a new patient visit would never really be completed in such a short amount of time. So now we get into the revised descriptors. So the old 2020 visit there is on the left side, where you had to have, you know, the three components: an expanded problem-focused history, you know, examination, straightforward decision-making, and the presenting problems were low to moderate severity. And the time there was listed as 20 minutes spent face-to-face with the patient or family. So the new description is that it's the office or other outpatient visit for the evaluation and management of a new patient, which requires a medically appropriate history and or examination and straightforward medical decision-making. When using time for code selection, 15 to 29 minutes is the total time is spent on the day of the encounter. And so I did go ahead and put the times in red font just so you could see the differences. And for new patients, the time increments go in 15-minute bumps. And the code descriptions were created with a range of time. And so but I want you to, so remember that the time range, and because that will come in handy when we are talking about the prolonged services. All right, so here we've got the 99203, where this is your low level of medical decision making. Typically, you know, the time's usually around 30 to 44 minutes for a new patient. And then the 99204 is moderate, so not a lot of change there. So, but the time is 45 to 59 minutes. And then 99205 is the 60 to 74 minutes for the high level of medical decision making. And then the CPT notes state that for when you hit 75 minutes or longer, then you can see the prolonged services codes. We'll have more discussion on this when we get back to the prolonged services. So just kind of keep that in the back of your hat. All right, so the 99201, really the change in the description is the last sentence, the time element is removed. And this usually, I don't know that I've ever seen a physician report it, but it's usually used for the nurse visit. All right, so now when you get into the 99212, this is again your straightforward medical decision making, and the established patients go in 10-minute increments. So now what this does is it's aligned the medical decision making for the codes. So the 99202 and the 99212 are straightforward medical decision making. Now the times elements are going to be different because it does take a little bit longer for a new patient. All right, and so here we've got the 99213. So this is your low level, again 20 to 29 minutes. The 99215, this is your moderate, or excuse me, the 99214 is your moderate with 30 to 39 minutes. And then you've got your 99215, which is the high level of medical decision making, or time, when time is used, it's the 40 to 54 minutes. And then for the prolonged services, if it's 55 minutes or longer, then you can start using your prolonged services codes, allegedly. All right, now I did want to throw in a new code that was it's going to be effective January 1st, and it was discussed in the physician final rule for a complexity adjustment. And there was really a lot of confusion and not much guidance given. And so I'm hoping that CMS publishes more to kind of give us a way to a roadmap so that we're able to use the code correctly. So the G2211, that entire rest of the paragraph is the code description. So visit complexity inherent to evaluation and management associated with medical care services that serve as the continuing focal point for all needed healthcare services, and or with medical care services that are part of ongoing care related to a patient's single, serious, or complex code. It's an add-on code listed separately in addition to your office outpatient evaluation and management visit, and it can be for a new or established. And the intent of the code is to help provide additional reimbursement for providers where you're going to have to establish a long-term relationship with the patient, and that can also involve delivering a team-based care that's accessible and also coordinated with other practitioners, and integrated with the broader healthcare landscape. Excuse me. And sometimes it helps to have some examples or kind of stories, I guess. So it says that you would use this for a patient that is, you have a 68-year-old patient with congestive heart failure, diabetes, and gout. And then she comes into your practice. Well, the example they said was a 68-year-old female patient, but gendered, it doesn't matter. For the clinical example anyway, but if she's, if you've got somebody with congestive heart failure, diabetes, and gout, they come in and see the doctor, and he does some prescription management, but the A1C is low, so he's wanting to do some education about, or her A1Cs are off. And so they're wanting to do some education regarding the diabetes and, some of the things that the patient needs to do. And so the expectation is that this would be a patient that you would see long-term. Someone asked the question, well, what if the patient is only there at your practice for 6 months? Well, that's not what the intent is. They could move to, we're up north. It could be somebody moves to Arizona. But the intent is that it's somebody that you're planning on seeing for many years. That physician is in charge of the care for those conditions, but also might have to, send the patient out to see specialists, just making sure that they're the focal point for all of that treatment. So those are the types of patients that you would use it on. They said, do not use for seasonal allergies. And it's not restricted to any specialty. So, it could be, a cardiologist could use this, any specialty could use this. Just that the expectation is that the provider is the focal point for the treatment, and it's going to include patient education, establishing expectations and responsibilities. There's some shared medical decision-making there around those therapeutic goals and commitments to achieve those goals. So there's still not a lot out there on when you can use that. Just the expectation is it's for a patient where you're going to be treating them for a long time. It would not necessarily be for like a newborn patient. If you're in pediatrics, you're expecting that you'll treat that patient until they're 18 or 20. But if they're, a normal newborn and you just see them for their, their basic well child checks on schedule and every once in a while for cold and flu, that would not necessarily be something where you would use that complexity adjustment. But if that patient also had something like cerebral palsy, juvenile diabetes, other things going on where you were seeing that patient on more regular intervals. So I'm sure hoping they come out with more guidance because it was nebulous at best. All right, so let's talk about what the time includes. And this is a list that is in the E&M guidelines. So it is available if you in the book there. And this is what's included when it's provided. So when you prepare to see the patient, so review of the tests. So if doctor is reading patient notes during the morning prior to getting started during the day, yes, that time does count. So obtaining or reviewing a separately obtained history, performing a medically appropriate examination or evaluation. So that can be included in the time. It's not the basis of code selection, though. The counseling and education of the patient or family or maybe caregiver, ordering medications, tests or procedures, and then care coordination. But I want to make sure that you notice that where it says not separately reported, it's very important that you do not count time twice. So if you are using the care coordination codes, like the transitional care management or the chronic care management, the time you spend, time counted towards the evaluation and management code cannot be used in those care coordination codes, and the care coordination code time cannot be part of the E&M time. All right, so you've got your documenting the clinical information in the health record and also referrals out to other healthcare professionals. So what's not stated is that you have to have specific start and stop times because it can be cumulative. So for example, you could see the patient at 10, but provide, education to the family or caregiver at 2, just as an example. And you could include the time for both. The intent is to allow the providers the freedom to see their patients, and then just make sure that you're not counting minutes twice. And so thinking ahead, even though the AMA does not say you have to have specific start and stop times, that doesn't mean that payers won't. So just, keep an eye on what your payer requirements are. And so the intent is that your provider's not feeling like they have to punch a clock. So just so that you're aware of that, this is not like the infusion or observation where you have to have specific start and stop times. But be aware that for other, some MACs and some payers for services that are time-based do require start and stop times, for example, for some of the psychotherapy services. All right, so some services that can be reported separately, so just be aware that if the physician is the performance or interpretation of diagnostic tests or studies are not included in the time spent. So if the provider is also doing an EKG and doing the reading or an ultrasound, and the provider is creating a separate report, just make sure that that time is not counted as part of the E&M time. So if they're, doing an ultrasound there at on the patient in the office because it's hard to see the digital images that are recorded, and doctor's just taking a look and is not doing a separate report and isn't charging separately for that, that ultrasound, then that can be counted as part of the E&M time. Just making sure, if you're going to be charging something separately for the service, that time should not also be counted as part of the E&M. And modifier usage is going to remain the same. All right, now for split and shared visits, they can, and I'm expecting regulations to change to kind of follow this. So it is going to also include face-to-face and non-face-to-face work, and it has the time spent personally by those providers is summed and used to define the total time. And of course, it's using distinct time, but time that is spent meeting jointly with the patient or discussing the patient is only counted once by one individual. So let's say the nurse practitioner sees the patient for 10, talks to the doctor for 5, then the doctor sees the patient for 10. You would count that as the 10 for the NP, the 5 for the discussion and 10 for the physician. So that would be 25. You would not count it 10 plus 5 plus 5 plus 10 for 30. So just be aware of that. All right. Medical decision-making updates. All right, so the guidelines for history and/or examination really starts off with a bang. The exam includes a medically appropriate history or exam when performed. And the emphasis is mine. I did that in red font. And then the other big change is the second bullet point. The extent of history and exam is not an element in code selection. That was actually at the bottom of the paragraph in the code book, but I really feel that that's such a huge change. The history and exam really is not going to be much of an element in the code selection. And so it's the history or exam, it's, the nature and extent determined by the physician or non-physician practitioner reporting the service. The care team may collect information, and the patient or caregiver may supply information directly, and that can be through a portal or a questionnaire. So it still should be reviewed by the provider, so they can kind of, still get credit. So that part is the same. All right, now let's talk about the number of and complexity of problems addressed. So it could be multiple new or established conditions that may be addressed at the same time. And so it may or may not affect the MDM. So the symptoms may be for a specific diagnosis, or each symptom is not necessarily a unique condition. So it could be a lump of symptoms is the diagnosis. So some symptoms, may cluster around a specific diagnosis, and each symptom is not necessarily the unique condition. So comorbidities and underlying diseases, in and of themselves are not a consideration in selecting a level of E&M services unless they're addressed and their presence increases the amount or the complexity of data to be reviewed and analyzed, because they're going to be taking a look at the morbidity or mortality and complications that are going to be part of that patient's management. And the final diagnosis for a condition does not itself determine the complexity or risk, because an extensive evaluation might be required to reach the conclusion that the signs or symptoms do not represent a highly morbid condition. So, and then kind of the opposite can be true as well, that multiple problems of a lower severity may, as they are stacking up, create a higher risk due to their interaction. And if something is on a problem list but is not part of today's visit, it does not count. So just because it's on the problem list, if it's not addressed and documented, it does not count. So these definitions are listed in the guidelines. And so the definition of a problem, this problem is used in the MDM or the medical decision-making table. So it's really important to note. So it's a problem is a disease, condition, illness, injury, symptom, sign, finding, complaint, or other matter addressed at the encounter. So it with or without a diagnosis being established at the time of the encounter, and treatment is dependent upon the patient's condition. A problem addressed, a problem is addressed or managed when it is evaluated or treated at the encounter by the physician or other qualified healthcare professional reporting the service. And that also includes consideration of further testing or treatment that may not be elected by virtue of risk or benefit analysis by the patient or the parent caregiver. And a notation in the patient's medical record that another professional is managing the problem without additional assessment or care coordination documented, does not qualify as being addressed or managed. So if like if somebody has gout, but they're seeing their family practice physician, and that physician's not addressing the gout during that visit, it does not qualify. But also make sure that, if the patient's coming in and, they're addressing whether the patient needs to have an MRI or a CAT scan, maybe during the decision-making process, the patient decides, well, no, I really don't want to have an MRI. Even though as long as the physician documents that can be counted, because it is a management option. They just chose not to select that one. And so, also checking the clinical decision support mechanism for the appropriate use can also count here too. So, all right, so let's take a look at a minimal problem. And a minimal problem is a problem that may not require the presence of a physician, but it is provided under the physician's or other qualified healthcare professionals' supervision. So basically that's your 99211. And kind of what they mentioned at the CPT symposium is, that's where it would be, you'd call Dr. Mom for those types of problems. Now, your self-limited or minor is one that is going to run a definite and prescribed course. It's transient in nature and not likely to permanently alter health status. So a little bit more intense. So we've got the stable chronic illness, and that's a problem with an expected duration of at least a year or until the death of the patient. For the purpose of defining chronicity, conditions are treated as chronic whether or not the stage or severity changes. So they're using the example of diabetes. So uncontrolled diabetes and controlled diabetes are a single chronic condition. Stable, for the purposes of medical decision-making, is defined by the specific treatment goals for an individual patient. And so that can change because all patients are different. And a patient that is not at their treatment goal is not stable, even if the condition has not changed and there is no short-term threat to life or function. And they provide an example here as a patient with poorly controlled blood pressure for whom better control is a goal is not stable, even if the pressures are not changing and the patient is asymptomatic. And the risk of morbidity without treatment is significant. And I want to point out that the emphasis on without there is in the CPT book. It was not from me. So examples may include well-controlled hypertension, non-insulin dependent diabetes, cataract, benign prostatic hyperplasia. All right, so now we move on to the acute uncomplicated illness or injury. And this is going to be a recent or new short-term problem with a low risk of morbidity for which treatment's considered. And there's little to no risk of mortality with treatment, and full recovery without functional impairment is expected. And it's normally self-limited or minor, but it's not resolving consistent with the definite and prescribed course. And it is an acute uncomplicated illness. And those examples here are your cystitis, allergic rhinitis, or a simple sprain. And now you have your chronic illness with exacerbation, progression, or side effects of treatment. And that's a chronic illness that's acutely worsening. It's poorly controlled, or it's progressing with an intent to control progression, and it requiring additional supportive care or requiring attention to treatment for side effects, but that does not require consideration of a hospital level of care. Again, I would think here of the patient mentioned in the previous slide with the uncontrolled hypertension, where maybe they're not responding to the, where the treatment goal is to get into a normal range of of tension, but the medication is maybe not treating them well. So there's still, if you don't take care of that patient, it can get worse. And then we have an undiagnosed new problem with an uncertain prognosis, and that's a problem in the differential diagnosis that represents a condition likely to result in a high risk of morbidity without treatment. And an example here is a lump in the breast. All right, and so we've got an acute illness with systemic symptoms, and this has a high risk of morbidity without treatment. For systemic general symptoms, there's like your fever, body aches, or fatigue in a minor illness that may be treated to alleviate symptoms. Might be, those are kind of your self-limited or minor, or acute uncomplicated, but your systemic symptoms may not be general, but it may be a single system. And for these, they give examples of pyelonephritis, pneumonitis, or colitis. And then we have an acute complicated injury, and this is an injury that requires treatment that includes the evaluation of a body system, or even that are not directly part of the injured organ. The injury is extensive, or the treatment options are multiple, or possibly associated with the risk of morbidity. And an example here may be a head injury with a brief loss of consciousness. All right, so here we've got the chronic illness with the severe exacerbation, progression, or side effects. And so here's just the severe exacerbation of those chronic illnesses. And then you have acute or chronic illness or injury that poses a threat to life or bodily function. And so here you've got an acute illness with systemic symptoms, or an acute complicated injury, or even a chronic illness or injury with exacerbation or progression, or having side effects of treatment that poses a threat to life or bodily function in the near term without treatment. Examples in this area include an acute myocardial infarction, a pulmonary embolus, severe respiratory distress, and also an abrupt change in neurologic status. And this takes us out of the types of different illnesses. And then the next set of definitions assist with other areas in the medical decision-making tool for selecting. So for the amount or complexity of data, they do have tests. So the tests include imaging, laboratory tests, psychometrics, or physiological data. And so if there are, you have a lab test for your T4 and another one for, and I'm going to say renal, and that's probably going to get me in trouble because I'm trying to, so like, let's say you have two codes for lab tests, so they're separate. But if you have something like a laboratory panel, like the basic metabolic panel here, that's one test. So just kind of remember that. So the differentiation between a single or multiple unique tests is defined in the CPT code set. And so this also includes a quick, easy access to the decision support tool. So the clinical decision support mechanism would also count in this area as well. So external, that's going to be your external records, your communications or test results that are from an external physician or other qualified health care provider, a facility or a healthcare organization, and your external physician or other qualified healthcare professional. And that is going to be an individual who's not in the same group practice or is a different specialty or subspecialty. And that's you're communicating information to an ordering provider, and it also includes licensed professionals that are practicing independently, and it can be a facility or an organizational provider like a hospital, a nursing facility, or a home health care agency. All right, now these definitions are kind of cool because you now have the definition for an independent historian and some examples. Now, because they've used the EG, it means that this not an exhaustive list. And so the independent historian is an individual who provides history in addition to the history provided by the patient, who's unable to provide a complete or reliable history. And that could be due to developmental stage, dementia, psychosis, or because a confirmatory history is judged to be necessary. And that could be where there's, a conflict or poor communication between multiple historians, or more than one historian is needed, and the independent historian is met. Now, this is someone that's able to provide history on what happened or what's going on with the patient. It is not someone who is a translator, because the translator is merely communicating what the patient is saying. And so it does not meet the definition of a historian. And an independent interpretation. And so this is the interpretation of a test where there is a CPT code, and an interpretation or report is customary. And so this does not apply when the provider is reporting the service or has previously reported the service for the patient. A form of interpretation should be documented, but need not conform to the usual standards of a complete report for the test. So that could be where, they sent the patient out to get a chest x-ray, the results come back, and instead of having the radiologist do the read and send the report, your physician is doing that. So the appropriate source, and so for the purpose of the discussion of management data element, the appropriate source can be professionals who are not healthcare professionals, but are involved in the management of the patient. So a lawyer, parole officer, case manager, teacher, and it does not include discussion with the family or formal caregivers, and that's, the communication to the patient. One example I can think of for this is when they send the attention deficit questionnaire to the teacher to fill out. That teacher is, and the test comes back, that the teacher is considered an appropriate source in that manner. All right, risk. And so that's the probability and or consequences of an event. And the assessment of the level of risk is affected by the nature of the event under consideration. So, there are examples of a low probability of death might be a high risk, but a high chance of a minor self-limited adverse effect of treatment may be low risk. So the definitions are of risk. So I really like this sentence, and I probably should have highlighted it. The definition of risk it's based on the usual behavior and thought processes of a physician or other qualified healthcare professional in the same specialty. So it's, saying, this is how we think clinically. And so the trained clinicians apply common language usage meanings to the terms such as high, medium, low, or minimal risk, and do not require quantifications for those definitions. But the quantification might be provided when there is the evidence-based medicine has those established probabilities. And so for the purpose of medical decision-making, the level of risk is based upon the consequences of the problems addressed at the encounter when appropriately treated. And that also includes the medical decision-making that might be related to the need for further testing or treatment or hospitalization. So it's very important to understand that the decision-making, this is how the clinical folks think. And so it's just their documentation is now a distinction of their, or, showing their thought processes, and not just trying to, check marks on a box so they can get the higher level. That's all right. So morbidity. So this is a state of illness or functional impairment that is expected to be of substantial duration, where that function might be limited, the quality of life is impaired, or there's organ damage that may not be transient despite treatment. And so, you might need to use a quick and easy decision support tool. And then social determinants of health, and that is your economic and social conditions that influence the health of people and communities. And examples include for food or housing insecurity. For example, one of the things that was related during the CPT symposium is that they had a patient that came in with a foot injury, and the treatment was, we'll keep a clean bandage on it for the next 5 days, use clean socks, make sure you're clean, keep it elevated as much as you can and stay off of it as much as possible, which sounds normal. Well, when you add other social determinants of health, like the patient's homeless, so they don't have access to, they don't have easy access to running water to keep the thing clean. They really don't have a place to store bandages. They don't have a place to sit down so that they can stay off of their foot, or anything to sit on to keep it elevated. So if the provider's office then is assisting that patient to find a place to stay for the course of treatment, that is also going to determine in there. And so it could be, if there are situations around the patient that are going to include, okay, well, this is what the normal decision making would be for this, but we have this issue, how are we going to solve it? So that kind of also can go into the amount and the complexity of data that's got to be evaluated and resolved for that patient. And so now this is going to be a factor in the code selection. All right, and then we've got drug therapy requiring your intensive monitoring for toxicity. And so it's a therapy, and so the drug that requires intensive monitoring, and it's a therapeutic agent that has the potential to cause serious morbidity or death. The monitoring is performed for assessment of these adverse effects and not primarily for assessment of therapeutic efficacy. And it should also be the generally accepted practice for the agent, but it may be patient-specific in some cases. And that intensive monitoring might be long-term or short-term. And they have defined long-term is not less than quarterly. And the monitoring can be by a lab test, a physiologic test, or imaging. And monitoring by history or exam does not qualify. The monitoring affects the level of medical decision-making in an encounter in which it's considered in the management of the patient. So the examples here include the monitoring for cytopenia in the use of their anti-neoplastic agents, whose dose cycles, or the short-term intensive monitoring of electrolytes and renal function in a patient who's undergoing diuresis. And what the bold font here is from the AMA and not me in this instance. So they're saying that monitoring glucose levels during insulin therapy as the primary reason is the therapeutic effect, even if hypoglycemia is occurring. And also annual electrolytes and renal function for a patient on a diuretic do not count because the frequency does not meet the threshold. So just remember, it's got to be kind of a high risk type of thing here. So code selection is going to be based on the level of medical decision making defined for each service, or the total time for the E&M service performed on the date of the encounter. Now, the medical decision making has 3 elements, and that's your number of and complexity of problems addressed, the amount or complexity of data to be reviewed and analyzed, and the risk of complications, the morbidity or mortality of the patient management decisions. So those are the three things. And there are now just the 4 levels of medical decision making: straightforward, low, moderate, or high. There is no medical decision making for 99211. And remember, the shared medical decision making involves getting the patient and family involved, getting their preferences, providing education, explaining the risks and benefits of the different management options. And so that medical decision making might be influenced by role and management responsibility. So it could be, if you're discussing treatment options, for a 92-year-old patient and undergoing that might need a hip replacement, well, it's, there are a ton of options there, and the patient may not, unless they have a broken hip or something, they may not want surgery in the first place. They might decide, oh, hey, the pain's not that bad, I'll live with it. So, so there, and the documentation of the discussion of that is going to be influential. And so now with those four types of medical decision making, the new and established patient codes parallel each other. All right, so remember, it's going to include your medical records and tests, other information that has to be maintained, ordered, reviewed, and analyzed for the encounter, can be from multiple sources, and it can be obtained from interpersonal communications that are not separately reported. And that's, again, if you're using those care management services for some of this, you count the time, you count it once. All right. So the amount of complexity is also divided into 3 categories. So you've got your tests, documents, orders, or independent historians, and each unique item is counted until the threshold has been reached. And the independent interpretation of tests, or the discussion of management or test interpretations with an external provider. And so the risk of complications and morbidity or mortality of the patient management decisions made at the visit associated with the patient's problems and diagnostic procedures or treatments. And that includes possible management options selected and considered, but not selected after shared medical decision making with the patient or family. So for example, a decision about hospitalization includes consideration of alternate levels of care. And the example provided here is might include a psychiatric patient with a sufficient degree of support in the outpatient setting, or the decision not to hospitalize a patient with advanced dementia with an acute condition that would generally warrant inpatient care, but the goal is actually palliative treatment. So just remember, possible management options discussed may also include options not selected. Okay, so there is a medical decision-making table, and it should be used as a guide to assist in code selection. And it contains 4 levels of MDM, 3 elements of MDM, and the risk of complications or morbidity, and must meet or exceed 2 of 3 levels. And then I've got this asterisk item here, and it's in the levels of MDM. Just each unique test, order, or document contributes to the combination of 2 or combination of 3 in category 1. I started to run out of room on my slides, so I put it as a bullet point here, because there's a lot of stuff on these slides, which you'll receive in an email, as I'm sure Dusty has posted in the chat area. All right, so here's our kind of a table of risk. So the 99202 or the 99212, this is your straightforward medical decision making. So the number and complexity of the problems are minimal. So that's one self-limited or minor problem. The amount or complexity of data to be reviewed and analyzed is minimal or none. And then the risk of complications or morbidity or mortality of patient management is also minimal risk of morbidity from additional testing or treatment. So it's very straightforward on this. Well, yeah, it's very straightforward. Okay, now if we get into the low here, and so this is where you have 2 or more self-limited or minor problems, or you have 1 stable chronic illness, or you have 1 acute uncomplicated illness or injury. And so the amount or complexity of data to be reviewed is limited. And so you must meet the categories of at least one of the 2 categories. So for category 1, you have tests and documents, so any combination of the 2. So there's 3 listed there. So review of the prior external notes from each unique source, a review of the results of each unique test, and an ordering of each unique test. So it could be that, you know, the patient got you ordered, you know, a lab test, the patient came back when you're discussing the results of the lab test, and then you end up ordering a different lab test. That's going to actually count a couple of times there too. And then the category 2, the assessment requiring an independent historian. And for that one, there is a parenthetical note that is going to direct you to the moderate or high level of medical decision making for instances where the independent interpretation of tests and discussion of management options. So it's telling you might need to bump up. And so then there is low risk of morbidity from additional diagnostic testing or treatment. So when we move into the next code, though, the moderate, we're actually going to have 2 slides on this one because I couldn't get everything in the amount and or complexity of data to be reviewed. And so just remember, you only have to have 2 of 3 to meet the code level. So if you have 1 or more chronic illness with exacerbation, progression, or side effect of treatment, or you have a patient with 2 or more stable chronic illnesses, or you have 1 undiagnosed new problem with an uncertain prognosis, or an acute illness with systemic symptoms, or 1 acute complicated injury. All right, and so I'm going to hop over to the risk, the far right slide there, and talk about the risk of complications or morbidity or mortality of the patient management. So the risk, there's a moderate risk. And so the examples include prescription drug management, decision regarding minor surgery with identified patient or procedure risk factors, and a decision regarding elective major surgery without identified patient or projected risk factors. And for the minor surgery and the major surgery, the AMA said, yes, they were going by the global surgical days. So the minor would be those with procedures that have the 10-day global surgical package. And then the major is the ones with the 90 days. And remember, this one is elective. If it's emergency, that bumps you up to the 205 and the 215. And the diagnosis or treatment significantly limited by social determinants of health. So that kind of bumps up the medical decision making quite a bit. All right. So for moderate, you have to meet requirements of at least 1 out of the 3 categories. So for category 1, you have your test documents or independent historians. So you have to have at least 2 of the following. So a review of prior external note from each unique source, the review of the results of each unique test, and an assessment requiring an independent historian. Or, now I'm going to go bump over to my next slide. I did go ahead and just copy over the first and third slide. So, or you have your independent interpretation of tests that was something not separately reported, or discussion of management or test interpretation. And that is the discussion of a management or a test interpretation with external physician or qualified healthcare provider or appropriate source. So remember, those appropriate sources could be like your lawyer, parole officer, and so it's not, but that was not an exhaustive list. So remember, you only have to meet one out of the three. So if you get of the amount or complexity of the data to be reviewed and analyzed. So as long as you hit, something in each category there, you're ready to go. All right. Now again, the high risk, you're going to have one or more chronic illnesses with severe exacerbation or your progression or the side effects of treatment, or you have an acute or chronic illness or injury that poses a threat to life or bodily function. And so there is an extensive amount of and complexity of data to be reviewed and analyzed. And for the 99205 or the 99215, you have to meet 2 out of the 3 categories. And so the high risk here is your drug therapy requiring intensive monitoring for toxicity, and excuse me, the decision regarding elective major surgery with identified patient or procedure risk factors, decision regarding emergency major surgery, a decision regarding hospitalization, and then also the decision not to resuscitate or to de-escalate care because of the poor prognosis of the patient. So that kind of goes along. And then with this as well, the amount of complexity, it remains the same between the 4 and the 5. It's just the amount of stuff that's there. And so I just wanted to list those here for you. So you will be getting these in the slides. And so let's go ahead and go along to the prolonged services reporting, because I do want to give you time for for some questions here at the end. And of course, CMS disagrees with the AMA on the time reporting. So the CPT, you noticed how with the new patient visits, the new patients went in 15-minute increments, and the established patient went in 10-minute increments. So if you are going to, in the physician final rule, CMS said that they were kind of confused by the description of the time ranges within the codes, which is odd because the AMA said CMS asked them to put the time range within the code descriptor. So it's kind of one of those, damned if you do, damned if you don't moments. And so when creating these, CPT uses the low end of time, but CMS is going to use the high end of the time. So an example here is you have your 99215, the CPT code description says it's for 40 to 54 minutes. The parenthetical note says for services 55 minutes or longer, see the 99417. Well, CMS, of course, uses the 54-minute mark. So the prolonged services don't really start until minute 69. And of course, then they had to create a new HCPCS code. So I don't quite understand this because the AMA has had stuff that they've published out on their website, and they've been in communication with CMS. So I don't know why they didn't get it ironed out. So the new HCPCS code is G2212, prolonged or other outpatient evaluation and management service beyond the maximum required time of the primary procedure, which has been selected using total time on the date of the primary service, each additional 15 minutes by the physician or qualified healthcare professional, with or without direct patient contact. And you would list this in addition to CPT codes, the 99205 or the 99215. And so, and then if, of course, they have reported, you don't report it for any time less than 15 minutes, and then don't report it on the same date of service. And there's some other prolonged services codes there too. So, so yeah, I mean, it's nice. They've provided another amazing opportunity to be even more confused on things. But let's take a look at some of the revised descriptions, because the 99417 is for the physician on the day of. And so there have been some revisions to some of the existing codes so that you have specific codes for the physician, or like your nurse practitioners and physician assistants, and then other codes for clinical staff. So that would be your nurse and your medical assistants. And okay, so we've got code 99354, and then because 99354 is for the first hour, and then 99355 is for each additional hour. And the code description here is just mostly a rewording, but just they did update it to say you're not supposed to use it with other CPT codes, and they've listed the CPT codes there in the description. And then also so then they also had to make separate ones for the psychotherapy services, and I did not list those here in the slides because we were talking about evaluation management and not psychotherapy. So lots of trickle down effect. All right, and so we've got a revised description for the 99356 and the 99357. And so again, for your initial hour, and then the 57 is for each additional hour. And so here these are the prolonged service in the inpatient or observation setting requiring unit or floor time beyond the usual. And then you would list this in addition to the inpatient or observation evaluation and management service. So what's nice is that the CPT book does have several table tips that they published in there. So this is for CPT reporting and not for a Medicare patient. All right, so no, strike that, because it only has to do with when the physician is providing the service. I apologize for that. So if you have less than 30 minutes, it's not reported separately, so it does get that mid-range bump. So if you have 30 minutes to an hour and 14 minutes, you have your 99356 times 1, 75 to 104 minutes, which is an hour and 15 minutes to an hour and 44 minutes. Then you can use the 99356 times 1 and 99357 times 1. And then if you get up over the hour and 45 minute mark, then you can report an additional unit of that 99357 for each additional 30 minutes of time there. Okay, so your 99358 and your 99359, this is the there is no major change. There's no change to the code descriptions, but there are significant changes to the guidelines. So you can use these prolonged services when it's when a prolonged service is provided that's not face-to-face time in the outpatient, inpatient, or observation setting, nor additional unit floor time in the hospital or nursing facility setting. You do use these during the same session of an evaluation and management service except office or other outpatient services. So you're not to use these with your 99202 through your 9920215. And it can be used for prolonged services on a date other than the date of a face-to-face encounter. So if you do use these services, I suggest that you really need to look at the guidelines and kind of dissect those. So, and this prolonged service might be reported on a different date than a primary service to which it's related. And it could be an extensive record review may relate to a previous evaluation and management service performed at an earlier date. And it must relate to a service or a patient where the face-to-face patient care has occurred or it's going to occur, and it relates to the ongoing patient care. So this could be when you send out to get some medical records from another office, and in the olden days when they'd send you paper, you had like a 2-inch chunk of papers to go through. In electronic day and age, that kind of have to rethink that. But it's where you have, so you're not just, it has to be an extensive record review. It's not just for a little onesie twosie thing that's not too difficult. All right. So here we've got the 99358, your prolonged evaluation and management service before and or after direct patient care, first hour, 99359, each additional 30 minutes. And then it has a bunch of do not report during the same date of service as you have your office E&M. Do not report during the same month with your transitional care management stuff. And then do not report when performed during the service time of your codes. And those are some of your other the care management services. So just, there are a lot of interweaving factors here. All right, so the other tool tip here, we've got, if it's less than 30 minutes, don't report. So again, your 30 minutes to an hour 14, your 99358 times 1, and then at mini 75, you can add on the 99359, and then once you hit 105 minutes or more, then you've got at least your 2 units of 2 for the 99359. So each additional 30 minutes would have information on that. All right, so just the facilities may not report the 99415 and 16. They would they have a B. So usually if it's there are other codes for using, but it might just be part of the E&M visit. So you have your 99415 prolonged clinical staff service, and that's it's supposed to be the service beyond the typical service time during an E&M service in the office or outpatient setting, direct patient contact with physician supervision for the first hour. And you use this in conjunction with your 99205 and the 99215. So what the codes based on time, and you would not report it if you're using that in conjunction with some of the other prolonged services codes. And we have another table tip just to kind of cover the units of service. All right, the 99416 is for each additional 30 minutes. And so it's used in conjunction with the 99415, and there are the parenthetical notes that I included from the CPT manual. All right. So here we've got the 99417, which is the new code, which is your physician service. And so this is the CPT manual version. And so if you have a service less than 75 minutes, you do not report it. And so if you've got the 99205 and you're at minutes 75 to 89, you would have the 99205 and a 99417. When you get to the 90 to 104 minutes, then you can have 2 units of service, and this is physician time. So this is not your clinical staff time. And then here is the tool for the 99215, because remember the times are a little bit different. All right, and then back here I have also included the CMS table tip because they also listed theirs backwards from what the CPT did regarding the minutes. So for the 99205, if you're at 60 to 74 minutes, you report the 99205. It's not until you hit minute 89 that you can, so that at minute 89 through 103, you can report the 99205 and 1 unit of service of the G2212. So they just, and it's supposed to be the total time is the sum of all time with and without direct patient contact, and including any of that prolonged time spent by the reporting practitioner on the date of service and of the visit. And then because the time range for the 99215 is a little bit different, there is a separate times table. So for the 99215, the code descriptor does say the 40 to 54 minutes. So these are for your Medicare patients. It's not until you hit the 69 to 83 minute mark where you can add that G2212 with a 1 unit of service, and the 84 minutes to 98 minutes to have the additional code there. So that's, I believe, oh, sorry, I didn't mean to do that. And so what I wanted to do real quick was I have, and I'm hoping, can you, are you able to see the PDF document I just pulled up?
We're still seeing your
okay.
PowerPoint.
Alrighty. So let me stop that share, and I will share what I want to share right now is this document. It is the table of risk, and it's difficult to get all of this into one nice, easy spot where we can all see it. And so here you've got your, so you only have to, so you can see it. This flows a little bit better and might be an easier option to use as, your table of risk, and to go through and kind of double check and practice doing some of your E&M codes. And so to me, what was interesting watching the CPT symposium this year for the E&M changes is that they had for you're looking at November of 2019, and somebody's got a cough and fever. What would the medical decision making be on that? Well, that way back in the olden days, that would have been, probably something you would consider straightforward or minimal, but you change to November of 2020 and somebody's got a fever and cough. It just underscores the importance of the elements of medical decision making that are now added into that mix. So I just thought it was kind of brought it all home to me, is how much better these guidelines might be for being a little bit more accurate in assessing what's really going on with the patient, and also the work involved in taking care of that patient. All right, and with that, I'm ready for some questions, Dusty.
All right, great. We got a bunch. I know everybody ready to go into next year with E&M coding updates. A lot to take in, obviously. So let me pull these up, and we'll get going. Start from the top. Can the physician count the time he spent documenting in the chart and or calling referring physicians after leaving the office?
Yes. As long
Okay.
as it's on the date of service that they saw the patient. Yes, that was, those were bullet points included um, in the time calculations.
Sure.
And so,
They may have asked that before you even got to that slide, I
oh,
think.
okay.
Next question is, would you build this code? And Tina, you may need to clarify what code you mean now at this point, but she said, would you build this code if you are using the same info to determine the medical decision-making for new or established patient visit? Do you have enough there to answer, or?
Yeah, I'm not really sure I can.
Okay. Tina, if you want to clarify that in the chat or the Q&A, we'll try to get back to that. Next one is on the code G2211 per the link below. The guidelines were updated 3 days ago. That looked like more of a statement.
Oh, okay. The G2211.
Yep. And she included a link in the next
Okay,
Q&A.
awesome. All right, thank you. Lots going on. Hard to keep on top of it all, but thank you.
All right, here's a real question. If patient calls same day with additional questions, can that time be counted when billed the E&M code based on time?
If they're talking to the physician.
Okay.
That's the qualifier. It's physician time. So if they're talking to the nurse, that does not count. It's considered packaged into the E&M, the work for the E&M.
Gotcha. Okay. One of the earliest slides seemed to indicate that 99211 can only be based on time. Is that correct?
No, they took the time out. So let me, now if I can see if I can stop sharing and go back to my slide so I can make sure I'm taking a look at it so that it is reading properly.
And while you pull that up, yeah, we'll make sure to get that AMA resource that Ardith had up right before this. We'll make sure that's part of the resource package that you guys
Yeah, let's see. So we were, and of course, I have it on my small screen. Let me move it over to my bigger screen. Sorry. All right, there it is. Yeah, so it's, yeah, there's no time involved in it. So usually this is going to be what your nurse is using, and it doesn't matter how much time or how little time she spends. It's just it may not require the presence of a physician or other qualified healthcare professional. And just remember that the nurse or the clinical staff needs to be working under the supervision of a physician, under a physician's plan of care.
Okay. We have someone that is confused by G2211 versus using a prolonged service code. Any clarification you can provide there?
The G2211 or the G2212?
Yep. They put 2211.
Okay, because the G2211 is a complexity adjustment. And so, yeah, it's really confusing. The comments, people said in the comments that they wrote to CMS that they were confused on how they would use this. And it's not that it's, and it's not that it's any additional time done. It's the establishing the relationship between the patient, where there might be instances where there's a little bit more coordination of care that's going on, and so, or the physician might have to be in a couple of different meetings with other providers regarding that patient's care, and it's just kind of to help bolster that. And I hope that was what they were asking, because the reason why I questioned is the G2212 is the prolonged services code that you would have to use for Medicare patients, because they're not going to pay for the 99417 code because of the disagreement regarding the time, the start time of when you would start counting the prolonged services.
Sounds good. If that wasn't your question, feel free to try to clarify that in the Q&A, and we'll try to get to it. Another time counting question here. Can the resident time or fellow time be counted in the physician time in a teaching facility?
Can I plead the fifth on that one?
Okay.
I believe it is the physician time only. In fact, the CMS was asked this question during the office hours call, and they did not have an answer either. So I'm expecting that they will have some kind of guidance come out regarding that. But for I was looking at some of the teaching physician guidance, and it seems to point to the time spent by the physician. But I do have in my advisor question that came in, so I should be able to get a little bit more clarity for you on that.
Great. All right, just so I am not making any assumptions, to bill an E&M code based on time, there needs to be some of that time that is face-to-face. It can't be all non-face-to-face. This may have been mentioned, but I may have missed it. Thank you. Just clarifying.
Oh, gosh. Yeah. I will double check, but it could be that it is non-face-to-face. But I will double check, because it does say it counts the face-to-face and non-face-to-face, but let me double check if it counts face-to-face or non-face-to-face, just to be sure.
Sure. Just so everybody knows, like if you go back to the webinar page where you registered for this on vitaware.com, that is where we're going to upload like the recording, the presentation, and then once we work through all the Q&A here, we'll make a document that actually types them out as well. We'll put that there once that is finished, but that'll take a little bit more time. All right, a couple more minutes, a couple more questions. Next one, if noted by MD that the medication for gout may affect the conditions being seen for, would you count gout as a problem for that visit?
If they've listed that and they are managing it, yes. And hopefully there is some discussion in the record of why they're changing the medication. But if that is missing, you may want to query the provider just to cover your bases.
Makes sense. I don't know if this question is too big for right now, but what is the impact on hospital emergency room E&M levels?
There wouldn't be any impact on the hospital emergency E&M levels, because facilities are supposed to use their own internal guidance for code selection.
All right.
And the 99281 through the 99285, those have not been affected by this round of changes.
All right, I think we can fit one or two more in. If the minor procedure is performed the same day as the E&M, but the decision to perform the procedure on the same date for the same condition while in the office for the evaluation. 10 ROS, 8 exam elements, in other words, comprehensive HPI exam, can it be a 214?
Well, you don't have to do the review of systems and the comprehensive exam anymore. That's not going to be an issue for the code selection. And so it's going to depend on kind of the age-old, did you know when they came in that that you were going to have to do that procedure? And there's guidance in the Medicare policy manual that I can send out to you, because there is an edit that Medicare has set up where you may not be able to report that separately. But none of that old guidance is changing. The only thing changing is how you select the E&M code. But I'll give you I'll get examples for that so that it's more clear for you.
All right, perfect. Unfortunately, that's going to have to be our last live question. Again, we're going to go through all of them though. There's a number of questions still outstanding, and so give us a little bit of time to get through those. If you want to make sure you get those, the best ways to make sure you do is to, one, sign up for our newsletter. It's on the footer of every page on our website, vitalware.com. Follow us on LinkedIn is where we share most of our stuff as well, because once we get this Q&A live and everything else, we'll make sure those are on our resources page on our website and everything else, and so that anybody can view those and find those resources for their own needs. We really appreciate you joining us. This was our last webinar of the year. I cannot believe it. It's been an awesome year. We've handed out, I think, somewhere around 15,000 CEUs for the year to everybody. So hopefully you're finding use for those, and we'll be doing plenty more next year as well. So keep checking back, and everybody have a good holiday season, and we will talk to you all next year.
All right.
Thanks,
Thank you.
everybody.